We're going to start the Transplant Symposium. As you know, today we're going to speak about access to transplantation services and how having a transplantation program can impact the community. So the first talk is by our fearless leader, Dr. Carolyn Rochon, who is Associate Professor of Surgery and Chief of Transplant, and needs no introduction to the people who are sitting here, but maybe to the people out in Zoom land. So Dr. Rochon is speaking on champion access to transplant, a public health benefit, access to transplantation, a community health benefit, in the Community Health Benefits Symposium.
Thank you. So I'm very thankful that we have, again, interest in transplant and that we are so passionate about transplant here in our hospital and in our community. The impact of transplant in this community is tremendous, and the impact of transplant in this hospital is also very, very big, as well as its historical value. And I feel very lucky to talk to you about that today. So when I think of transplantation, like people just think, I always remember as a medical student, there was a nephrologist with a lot of white hair who I remember he was not a believer in transplantation, and we don't see those anymore. He used to say, oh, transplantation is a vanity project, but nobody has shown that it's truly beneficial. Now, that was a long time ago now, but I think that now we've really shown how beneficial transplant is. So it is not just a different type of renal replacement therapy, but it really, kidney transplantation helps a recipient live longer. It helps them live better. They can eat better. They can travel. They have a better lifestyle. They have a better mental health. They have better cardiac health. And they also have better mental function, which is so important. Like I don't know why they're all accountant, but I can remember specifically 4 or 5 accountants that I've transplanted, and that after transplant had told me, I need to go back at the taxes I did 2 years ago before my transplant, because I think so clearly now. I'm wondering if I was really thinking clearly when I did that before. And so the impact on mental function and speed of mental function is tremendous. The sad truth about transplantation is that despite all of our advancement, we still have enormous disparities in access to transplantation. And so I'm going to spend a few minutes talking to you about that. This slide here shows access to transplantation, kidney transplantation in Mexico. And you can see, at the bottom, you can see that the patient on the wait list, the top left corner shows you the number of patients on the wait list in Mexico has been going up every year. But meanwhile, the rates of transplantation in Mexico have really stayed the same, which is the slide at the bottom left. And you can see there that overall it's about 20 per million population, and it's been stable there since the early 2000s. And in the United States, we're at 76 per million population, and so huge changes in access to transplantation. There might be some differences in incidence, you might say that's true, but not that great. And then if you subdivide, the graph that you have on the right is the number of patients transplanted by their county of origin, by their address county, so not where they were transplanted, but where they were born. And you can see that access to transplantation has a huge disparity in Mexico according to where people live and where people were born. And so that enormous disparity, right, needs to be addressed. And I think that as Americans, we go, but that's in Mexico. We're much better in the United States. So here is a difference in access to liver transplantation in the United States. And so you can see that the access to transplantation per incidence of liver disease and of listing varies tremendously according to where you live in the United States. This graph is from data before the redistricting of the organ allocation in liver that aimed at decreasing the access to transplantation disparity based on geographic location. But, I think that when you look more closely, we still have, in the United States, huge discrepancies in access to care in transplantation. It is an area of care that has limited resources, and everything that we do has huge impact on where our field go and how the patients access it. And so it's really important that we don't only focus on what care we can provide, but who we provide it to and where the justice is and how we provide it. The graph on the right also gives you a difference in access based on a lot of demographic data. And you can see the variability that is there, how wide each of the lines are, is the differences you might find between different programs across the country. So how different patients are based on their race, their sex, their age, when they access to transplant in different counties is also still very varied in the United States. I just need to touch this a little bit. So here this graph it still looks at a geographic disparity in liver transplantation. And what I like about this paper is that it discusses that there's also differences in rate of organ donation, because there's differences in rate of preventable death amongst the states, right? So this is differences in preventable deaths in accidents in Massachusetts, South Carolina, and Florida. And all the differences are in heart disease, cancer, stroke, chronic respiratory disease, and accidents. And so as you go from Massachusetts, South Carolina, and Florida, the access to tertiary care changes, tertiary care health center changes, the helmet laws for people in motorcycles change, and therefore so do the number of what we call in the United States preventable deaths. And so interestingly, So therefore, some of our disparities in transplantation might not just come from access, but from availabilities of organs. And this is where there are some controversies in the United States, where some of the states that have more preventable deaths than other, therefore also have more donors and better access to transplant, and are debating whether it's fair to send these organs in states that have less preventable deaths and lesser access to transplantation. These are fair points. And for example, Massachusetts, which is a very safe state, has fewer eligible donors per million population than South Carolina or Florida. Florida is one of the highest eligible donor in the United States. They also have one of the fastest transplant rate in the United States. In New York, we call it the fifth borough. A lot of our patients are double listed in Florida, hoping to jump on the plane if they get called. And so these are things that, when we talk about access to transplantation, because of where we get our resources in transplantation, unfortunately, these things have to come to mind. Another significant disparity in transplantation that we often don't discuss enough is the geographic location and the distance between the dialysis center where the patients are cared for and transplant centers. And this is well documented. And this slide is very busy, but the main thing to know is that this first slide here is used as the reference number of 1 if the transplant center is within 10 miles of the dialysis center, right? These patients would have an access to transplantation of 1. And if they are between 10 and 20 or 10 and 50 or more than 50 miles, if their dialysis unit is more than 50 miles, their access to transplantation significantly decreases. And this is true also of areas where distances are greater. For example, the Midwest, access to transplantation is a lot lesser than the Northeast and the the Western states have one of the poorest access to transplantation. And so these geographic disparities are something that a lot of transplanters think should be addressed, and a lot of others think are sort of natural history of utilizing limited resources. Now, obesity is one of the it's the problem, is the healthcare problem of our day. And you can see here, this graph basically shows something that's been shown, like if you Google, if you PubMed obesity and transplantation, there are papers going back to the 90s. And there's a landmark paper by Dr. Segev in 2006 that really discusses how obese patients with BMI more than 35 or have a longer time to transplantation, have a higher rate of denial for listing, and are often skipped for different offers rather than transplanted when an offer does come to them. And so the morbidly obese, which is one of the fastest rising population in the dialysis population with end-stage renal disease, is also one of the population that has the poorest access to transplantation. And so you can see here significantly below for male and for female, so female even more than for male, have a lower, when morbidly obese, this yellow line here has a much lower access to transplantation than their skinny counterpart. And this is despite the fact that outcomes have not been shown to be worse in terms of graft survival for the morbidly obese patients. We know very well in Brooklyn the issues of racial and ethnicity difference and barriers to kidney transplant. This slide shows here, it was done by surveys sent to patients who were evaluated for kidney transplant. And what it basically shows is that a lot more Hispanic patient and a Black patient in the United States, significantly more, right? The dark lines here compared to this pale gray line, and all three, the dark line, the black line and the dark gray line compared to the white line, shows differences in perception and education and referral to transplantation, in understanding the benefits of transplantation, in understanding the importance of pre-listing testing for their access to care. And so we as transplant centers, I believe, are failing a lot of these patients by not adapting our education, our focus, and our resources to increase their access to care. These are preventable issues that can dramatically change access to transplantation, and still are getting reported with, this article is from 2018. So this is not, the disparities are still there, and there's still a lot of room for improvement in terms of racial disparities of access to transplantation. But there is good news with regards to access to transplantation, and there is a lot of work being done in improving access, and I think we've done a lot of that work, and we're still doing a lot of that work here at Downstate, and we're very proud of it. So the access to transplantation to the elderly is something that our program has really focused on and benefited from. And this is a slide that I really appreciate, because it really shows you, what it shows you here is that this is survival benefit for patients with different functional status. And what it shows you is that all of those survival here, if you have, and this is by different sort of quality of kidneys, right, by the KDPI. So the graph up here is like the best of the best kidneys, and then the medium sort of KDPI kidney, and here you have the highest KDPI kidney, so the kidneys that are more considered, used to be called marginal. You can see the huge benefit, the survival curve here, if you see this little dotted line, that's the survival of patient on dialysis. And so all of the different functional status are having a survival that is equal. The pale blue is the patient with the worst functional status you can find. These patients' survival with the transplant is not worse than on dialysis, it's actually the same. And then everybody else who has a better functional status, no matter what kind of kidney you give them, they do better than on dialysis, except if you give them a kidney that's 100% KDPI. So the absolute worst kidney that we get called for last night, if you give that to the least functional status patient, you will, and I'm pointing at Ryan when I say that, if you give that kidney to the worst functional status, they will have a survival that is equal to that one on dialysis. And so to really drill that into the referring providers' minds, that everybody should benefit from referral to transplantation and risk assessment, and that every organ can be used to get patients off dialysis, really is the new way to advocate for access for transplantation. This is just the data that I, with like a couple of medical students, were presenting at ATC in a little poster. And we looked at organ acceptance rates across all the different kidney transplant programs in the country. We excluded programs who do less than 10 kidney transplants a year. But we looked at everybody else, and we said, our patients, or our transplant program, we have a higher organ acceptance rates. Do they provide better access to transplantation? And we looked at race and ethnicity, at gender, and then we looked at age. And the results were not significant for race, ethnicity, and gender, but they were significant for age. And so it turns out that programs who aggressively decrease organ discard and have increased organ acceptance rates will increase the proportion of elderly patients more than 65 that they transplant, compared to programs who have lower organ acceptance rates. What is interesting is that high volume centers who do more than 100 transplants a year, do not transplant as high of a percentage of elderly. So that does make sense. You know, it doesn't mean that they transplant a lesser number, that's being said, because they still transplant high volume. And so although their percentage of elderly is lower, but they don't have an elderly focused sort of care as much as transplant centers who do less than 100 transplants a year might have to increase. So what that says to me is that the best place for access to care that a patient who's more than 65 can find is a program that does less than 100 transplants a year with a high organ acceptance rate. And those large centers did not transplant more Hispanic or African American patient. And the programs who did provide higher access to African American patients, where more than 45% of their patients were African American, had actually, sadly or interestingly, a lower offer acceptance rates, lower offer acceptance rates of high KDPI kidneys, so those riskier kidneys, lower offer acceptance rates of hard to place kidneys, which are kidneys that we're high utilizers of, like the kidney that everybody else has said no to. And what is also important to say when we talk about changing access to care and decreasing organ discard is that often organ acceptance rates and transplant rate ratios, right? The rate at which you're expected to transplant patient to be equal to national average, were in no way related to the program's risk of graft failures. So one of the big reasons why a lot of these centers are skipping on these organs is the fear of poor quality. But centers who accept these kidneys with high rates are not centers who have lower outcomes. Which is some of the things I say often, right? Like, if the kidney worked before, it's going to work after. It's just we have to master the art of keeping the patient alive until it works. And again, this is to sustain the idea of being eye organ acceptors and improving access to care. The line here that you see is the rise in risk of death on the wait list as a patient increases their rate of organ refusal. So if a patient gets transplanted and has only had 2 offers that were refused from them, they die on the wait list at a much lesser rate than those who've received 10 offers that were refused, right? So programs who constantly get offers for their patients and refuse them have much higher rates of death on the wait list than those who accept organs and get their patients transplanted. And so if you're an elderly patient or a frail patient or a patient who has a short window to get listed in a conservative centers that is not a high organ acceptors can actually be a death sentence. And I think to strike the mark, I think that some of the bad consequences in transplantation of being so regulated regarding graft survival is that people forget about the survival benefit of transplantation and only focus on the potential graft survivor. What you see here is the traditional survival of elderly patients in the community, and see how much it drops once a patient more than 70 starts dialysis. So bringing that patient out of dialysis and back into a functional community member raises their potential survival a lot, and should not be dismissed for the sake of potential good outcome. This is, and at the same time, elderly patients, but at the same time, the expertise and collaboration of centers who wish to transplant the elderly with specialized care, geriatric care, and big support is important, because once you've transplanted a patient who's more than 70, if they have graft failure, the risk of death is enormous. So once you've decided to put a patient with a hazard ratio of more than 4, right, for death. So once you've decided to put an organ into an elderly patient to keep that graft and sustain that graft viability is the most important thing that will keep them alive. Now, transplant has a long-established survival benefit, even though this remote nephrologist, when I was a medical student, doubted it. And this is a very old New England Journal of Medicine study from 1999, right, that had shown, this is when we started to quote it, that had shown that the survival benefit of transplant comes at 90 days on average. So once a patient has survived 90 days from their transplant, now their survival post-transplant is exceeding their statistical survival they had on dialysis, right? So it's 90 days is when you derive. So if you're able to survive 90 days from transplant, you will survive, you derive the survival benefit from transplant. And that, what is shown here in the left graph is that that 90 days is an average, right? The patient who is more than 65 actually takes them a year to get that survival benefit, but the patient who is 19, it takes them 3 days to have a survival benefit. So the 90 days was an average back in 1999. But this is a study from 2004 about the survival benefit post-transplant, and it shows that for patients more than 70s, the survival benefit is now at 9 months. And so if a patient survived 9 months, more than 70-year-old patient survived more than 9 months post-transplant, they've derived a survival benefit from being transplanted. And that survival benefit is true at all ages, but of course here in the graph to the right, you show that the older the patient, the greater the benefit until you hit about 80. This is, what I alluded to before, that access to transplant for the morbidly obese is important, and that once these patients are transplanted, their long-term graft survival and patient survival is much greater than if they stayed on dialysis, and it is not different than non-morbidly obese patients. And so I just want to wrap things up by discussing what we do here at Downstate to be champions of access to transplantation. So we use data-backed tools to assess candidacy in the elderly, and we really deep down and focus and have deep team conversation about each of our referred patient above 65's candidacy, and we really try to use data to deny people, not just looks and nice notes in the, and you'll see us, if you join our meetings, you'll see us use these tools at every single meeting. We have no BMI cutoff except for patients who are less than 65 and no peripheral vascular disease and have no CAD, which is consistent with the literature. And we use a diverse team who is a member of the community, understands our patients' barrier, and helps them get the care that they really need and deserve. And you can see here, this is our latest SRTR report that shows that our transplant patients are 98% non-white, which is representative of the community we serve, and I think is representative of how there is disparity for access in these patients, and they feel good in our healthcare system, and they know that the best care for them will be provided here by the people who care about their outcomes. And our ratio of elderly is higher than the region and of the country. And that's all I had. Thank you. Any questions? All right. So if there's a question. Oh, yeah.
Before we talk, how should we be thinking about higher KDPI kidneys and transplanting into younger individuals? Obviously, you're causing the population to be older in your transplant center when you're accepting higher KDPI kidneys. Is there some understanding that we should be careful with the younger patients?
Absolutely, and we see this all the time, and I wouldn't say, so I like to, so KDPI is just statistics, right? And sometimes oh, good. And sometimes because of, you'll be surprised how a donor might have a small history of hypertension, and you enter, they showed up to the hospital in AKI, and all of a sudden the KDPI is really high. Meanwhile, this person has perfect kidneys, and the KDPI is high, and everybody's starting it down. So one of the big discussion in transplant is not all KDPIs are born equal. Also, like KDPI is a ratio, and it discusses and it entertains all kidneys that were used in the past 2 years, right? So as we learn more about kidneys and we become higher utilizers, then 99% this year was probably not used a few years ago, and now that the organs that we now use will be part of next year's 99%, but were not used 2 years ago, and so something that is 85 today will probably be 80 in 5 years that we expand access, because that's how the KDPI keeps being recalculated based on the organs utilized 2 years ago, if that makes any sense. So the higher KDPI kidneys definitely, or their longevity is increasing every year. And as we become better at sustaining the GFR of these grafts also, and dealing with the initial DGF, delayed graft function that they might encounter, because they weren't like just the perfect machine that the 20-year-old kidney might be. But more importantly than the high KDPI, I think what we're very good at utilizing is that what I call the overlooked kidney, the 30-year-old kidney that creatinine rose to 7, but had no kidney disease. This is just a kidney and the whole country is turning it down. And we've been utilizing these kidneys a lot into elderly patients, because we're like, we don't know how this kidney is going to behave. And then, when the 75-year-old has a creatinine of 0.8 at 3 months, we all say, maybe we should have put it into the 55-year-old who's been waiting for a while. So I agree with you. I think that, there is a shyness in the middle of the night when your number, like 7,000 in the country for a kidney, and you go, wow, everybody else in the country doesn't like this kidney, but I think I can make it work. And I don't want to be too arrogant and also give it to a 50-year-old. But I think we are in the process of learning from this high acceptance behavior and bringing it back to benefit those who have the longer expected post-transplant survival, as you're pointing out. I don't know if that answers your question, but overall it's a yes. We're getting better at making them live long and utilizing them in all patients. Thank you for that question.